has started.
My name is Megan Kasani, and I am the Patient and Family Engagement Liaison at Ranken Jordan. For those of you who are unfamiliar with Ranken Jordan, we are a pediatric hospital helping kids from birth to 21 who are well enough to leave a traditional hospital but still need help before they go home. So we're in St. Louis, Missouri, so in the heart of the Midwest. We specialize in caring for children and families with the most complex conditions, illnesses, and injuries, and bridge the gap from hospital to home. Ranken Jordan's mission of care beyond the bedside means our kids spend 70% of their waking hours outside of their room because we know that playtime is natural for kids and promotes healing. A typical day for patients at Ranken Jordan could include anything from painting and playing golf to strumming a guitar or even hitting a home run on the diamond. So just a little housekeeping before we start. Our presenters want this next hour to be as engaging as possible. So if you are able, we would love to have your camera on throughout the presentation. We would like you to mute yourself just to kind of decrease some of that feedback throughout. And there will be time at the end for questions. So please feel free to type them in the chat bar throughout so you don't forget them, that kind of stuff. And I'll be monitoring the chat function throughout the presentation. Now I would like to introduce our speakers for the evening. First, I'm going to introduce Dr. Rachael Juehring. She is the inpatient psychologist at Ranken Jordan. She works with chronic and acute medical conditions, including traumatic brain injuries, spinal cord injuries, and other medical complexities. Dr. Rachael has trained at the University of Florida and Children's Medical Center in Dallas. Rachael previously worked as the endocrine psychologist at St. Louis Children's Hospital. And our other presenter this evening is Dr. Claire Wallace. Dr. Claire Wallace is a pediatric psychologist who leads the hospital's outpatient psychology service. She works with medically complex patients who come to the hospital for outpatient therapy or clinics. Much of her work involves co-treatment with physical, occupational, and speech therapies, as well as physiatrists and GI physicians. She has worked at children's hospitals in Cleveland, Columbus, and St. Louis. So with that, I am going to turn it over to Dr. Rachael and Dr. Claire.
All right. Hi, everyone. I am Rachael. I'm going to get started. Claire will be here socially distanced.
Hi, and now bye.
So I'm going to take my mask off just to help with sound and so you can see me. And thank you for the people who turned your cameras on. It's nice to, since we can't be in the same room, it's nice to see who's here. And if you guys have questions or comments throughout, I can't see the chat bar on the screen, but Megan can stop us if anyone has any comments or anything. Feel free to jump in at any point. So tonight's topic is it's a little heavy. It's a very serious topic, but I think it's very important. We have some good information that we are excited to share with you, and hopefully you can learn some good stuff and some new resources. I can always do that. Okay. So this is what we're going to be talking about. So first, we're just going to talk about some common risk factors and warning signs of suicide and mental health concerns. Then we're going to go over some talking points and different ways to communicate with your children, or I know we have, I think, some high school students on, so with your peers, friends, if you have concerns about their mental health. And then we're going to share some of our favorite community resources with you all. So the first thing that you might be asking is, like, should we be concerned? Should I be concerned about suicide in my child or in my friends, or how concerned should we be? And I wanted to start off by talking about, like, the goal of this talk is to not make you stressed. It's not to make you really worried. It's really to help increase your comfort having these conversations, to increase your comfort with knowing what to look for and then how to ask about it. Claire and I were talking while we were putting this together, and we both had the same experience, that moment, the first time that we had to ask a patient about if they felt suicidal, which is something that we do consistently when we meet new patients, and it's a hard question to ask. You don't know what they're going to say. You don't know what you're supposed to say back. It's a hard topic. So our goal is just to help you increase the comfort, feel more comfortable. Okay, so first we're just going to go over a few terms to know. The first is suicidal ideation. So this is more the thoughts or ideas about doing something to harm yourself. So it can be more passive, or you can have more active thoughts. And it's important to know here that suicidal ideation, those thoughts about death and dying, are a symptom of depression. So someone can have some passive thoughts and have depression, but they don't have that intent. So the suicidal intent is having a plan, taking steps, preparing to do something to harm yourself. So the difference between those two, and then that's also different from non-suicidal self-injury, or the abbreviation NSSI. So that's when you think about that self-harm. So behaviors to harm yourself without the intent to kill yourself. That might be things like cutting, burning, causing yourself to have bruises, different things like that. So non-suicidal self-injury is really a whole talk in and of itself, so we're not going to talk about that here, but you often see self-injury associated with things like depression, anxiety, suicidal ideation. But just because you're self-injured doesn't mean you're suicidal, and if you're suicidal doesn't mean you're necessarily self-injuring. So they can be related, but not always. So now to talk a little bit more about what depression feels like, what this intense emotional experience feels like for people. This was a great quote. John Ackerman is the leader of the Suicide Research Center at Nationwide Children's Hospital. And he wrote, "This intense emotional pain, hopelessness, and a narrow negative view of the future interferes with balanced decision making." So focusing on that intense emotional pain, hopelessness, and having that narrowed view, not being able to see the multiple paths in front of you. And I think it's important to understand kind of what that experience is like, because it helps us know what language to use. And in the situation, in all situations, language really matters. Language really changes our perception of other people, of the world, how we see things, how we think about things. So using some terms creates different associations than using other terms. So for example here, it's very normal and very common for people to say committed suicide. That's a term we all use. I've used it. But when you use the word committed, that really has a connotation of blame and stigma. And committed is associated with other words with negative connotation, like someone who committed a crime or someone who committed a sin. And so it really places more of that blame on the person. And it also ignores the fact that suicide is often the consequence of an unaddressed illness, like depression or trauma, and that we need to really think about these illnesses as any other health condition. So for example, if someone has a heart attack, you don't say they committed a heart attack. You say they died because of a heart attack. So to help kind of reduce stigma around mental health and to help people feel more comfortable asking for help, using language to say died by suicide can help with that. It's the same as saying that they chose suicide or that there was a selfish decision. Because what we know is that suicide is not something that we always think about as a choice. It's not always logical. It's an irrational behavior for something that in that time might feel like it makes sense. But to us on the other side, it doesn't always make sense. The same as saying that a suicide was successful. So instead of saying that a suicide was successful or a suicide failed, using language such as saying someone died by suicide or is a suicide death. So this is another great quote. "Those who experience the kind of emotional pain associated with suicide do not typically want to die. They wish for an end to unbearable emotional pain, and often the resources that allow them to hold on aren't available." And I really, really love this quote because, again, it takes that blame, it takes that choice, it gives you different language to describe that emotional experience. So it's not wanting to die, it's wanting to stop that horrible pain that they feel. So what do we know about suicide? So we know that suicide is the second leading cause of death among 10 to 19-year-olds. We know that boys die by suicide at 3 to 4 times the rate of girls. Between 1991 and 2017, suicide attempts among Black adolescents increased by 73%, which is a huge factor. And so, one of the reasons it's possible that there was this huge increase is that Black children and teens often have mental health symptoms that are classified more as disruptive behaviors, defiance. They're seen more as a behavior problem and receive discipline rather than receiving the mental health care that they really need. Another interesting fact is that rates for both boys and girls decreased in the early 2000s, but then began increasing again around 2006. We were doing a little bit of digging to see kind of what was associated with that increase, and it doesn't look like there's one clear factor for the increase. One possible reason is that social media started really picking up around that time. Facebook came out right around then, became accessible to the public, I think, a little bit after that. But that doesn't explain everything, because other countries that have the same usage of social media don't necessarily have the same increase in suicide rates. There was also the recession in 2008, could be stressors related to climate change, cost of college, just all the stressors that youth and teens are experiencing, in this time. Most children and adolescents who attempt suicide have a significant mental health disorder. It's usually depression. And it's also important to note that youth suicide rates remain lower compared to every other age group. So even though it's the second leading cause of death in this age group, it's still lower than any other age group. Okay, so that's kind of a quick summary of what we know, but now the question is, well, what do we do? And so the two most important steps in preventing suicide are recognizing warning signs and then getting help. So we're going to talk about both of those next. So risk factors are the things, the factors in your environment that increase the likelihood that someone may commit suicide or may have a suicide, see, I said commit suicide, or may have a suicide attempt. So there's different kind of groups of them. One of the biggest risk factors is access. So this one is huge. Access to highly lethal means during a crisis significantly increases the chance someone dies by suicide. So guns are used in nearly half of youth suicides nationally, so huge number, and about 90% of attempts with firearms are fatal, whereas just 4% of suicide using other means are fatal. So much more likely to die if you have that weapon, that means. Other factors in your social environment, bullying is a huge risk factor, and we're actually going to talk about that one more because it's so important. Family history of suicide attempts is also a risk factor. Exposure to violence, loss of a close relationship, so a death in the family, a relationship breakup is a risk factor. Stressful family dynamics in our environment in the home, an academic or family crisis, and also exposure to suicide through the media, family, or friends can increase suicidal ideation, intent, and attempts of suicide. And then the third kind of group of symptoms here are those internal characteristics, mental health concerns. So we talked about depression being a huge factor. Up to 75% of people who attempt suicide have depression. Aggressive or disruptive behavior can also be a risk factor. Hopelessness and helplessness. Impulsivity, regular drug and alcohol use plays a huge role, and then also having barriers to mental health service. Not being able to access the support you need is another big one. So we wanted to talk a little bit more here about bullying. So bullying is defined as unwanted aggressive behavior among school-aged children that involves a real or perceived power imbalance. The behavior is repeated or has the potential to be repeated over time. So there's different descriptors of bullying also. So I put physical and verbal together because those are the ones you really think about when you think about bullying. So, physical, punching, pushing kids, shoving, hitting, tripping, damaging property. Or verbal bullying, so starting off with name calling, insults, teasing, going to intimidation, possibly homophobic or racist remarks, verbal abuse. So those are the ones you read about in books, the ones you see on TV or in the movies, the ones that you might hear about kids experiencing most often. But then there's also the social bullying or relational bullying that's a little bit more covert. So it's harder to recognize and can be carried out behind the bully's back or is often invisible to adults in their environment as well. So this is the kind of bullying that's designed to hurt someone's social reputation or cause humiliation. So it can include things like lying, spreading rumors, negative facial or physical gestures like behind their backs or to them, but behind the teacher's back, playing nasty jokes, embarrassing, humiliating, mimicking them. You also see encouraging people to socially exclude someone, so saying, okay, I'll be friends with you, but that you can't be friends with so-and-so over there. And so then that person that was excluded has been socially bullied. And then finally, we have this cyberbullying. So for cyberbullying, this one's a little bit newer, and this is defined as intentional and repeated harm inflicted through the use of computers, phones, and other devices. So behavior that happens online. And it really happens about the same amount as bullying in person does. So about 15 to 20% high school students will say that they were bullied. And it's really the same kids that are bullied in person as the ones that are being bullied online. And so this can include things like abusive or hurtful text messages, email posts, images, videos, excluding people, gossip rumors, and imitating other people, trying to log in under their usernames and posting information from their own. And I don't know if anyone here remembers the big story back in 2006 about a teenager named Megan Meyer who was bullied online by friends, and even one of the friends, or I guess peers rather than friends, and one of the peers' moms created a whole account and was pretending to be some boy that was interested in her and bullying her online. And so this was Megan Meyer, and she was actually born in Florissant, and then this incident happened in Jardine Perry, so it's a local story. And she killed herself a few months before she turned 14. And because of this, Missouri created some new legislation to help prevent and reduce cyberbullying. So schools needed to provide more education on cyberbullying. But that was a local one that always kind of hits close to home. So bullying, huge risk factor for suicide. And then the other one is LGBT youth contemplate and attempt suicide at much higher rates than youth who do not identify as LGBT. And their attempts are also often more violent and require higher levels of medical care. So they have about 3 times the amount of suicidal ideation and 5 times more suicide attempts. I mean, that's significantly more. This statistic is also fairly sobering. 40% of transgender adults have attempted suicide, and of those individuals, 92% report having had a suicide attempt before the age of 25. So 92% of people. That's a huge number. And LGBT youth who come from highly rejecting families are 8.4 times as likely to have attempted suicide as their LGBT peers with strong family support. And then finally, each episode of LGBT victimization, such as physical or verbal harassment or abuse, increases the likelihood of self-harming behavior by 2.5 times on average. And so we wanted to call this out to really emphasize our individual and collective responsibility in supporting the well-being and mental health of the LGBT community. So we need to take responsibility in promoting a culture that is welcoming, that is affirming of diversity and supporting people for who they are, because this shows how much social support can impact, or lack of social support can impact someo's health. So really, it's not identifying as LGBT, it's not identifying as LGBT, it's really the lack of social support, the rejection that increases mental health concerns and suicide attempts. And then finally, COVID. I think, everyone here is pretty sick and tired of COVID and feeling kind of the COVID feelings. I had one friend who is a psychologist and just has a great way with words kind of describe her mental state as fragile. And everyone that I've talked to and kind of used that word has been like, yeah, that's a good word. I've been feeling fragile. And so the question is here, is COVID at all related to suicidality? Is it increasing teens' use rates of suicidal ideation? And so we don't know yet. That data will probably come out down the road. The data that the CDC has released shows that younger adults, racial ethnic minorities, essential workers, unpaid adult caregivers are reporting disproportionately worse mental health outcomes, including increased substance abuse and elevated suicidal ideation, but there's really no data on youth quite yet. And, there's the question of, will it increase the rates? So what we know is that, we went through all those factors, and there's usually not just one factor that leads directly to a suicide. So one pandemic might not necessarily lead to suicide. And also, people are having different responses to the pandemic. So if we think about school closures, for some students, that's devastating. So some students are missing the peer interaction, participating in athletics and extracurricular activities, struggling with virtual learning, and are really struggling. Other students maybe enjoy or feel relief about being able to do virtual school or stay from home, or they're enjoying being able to spend more time with family as a result of this crisis. And so different responses can have different outcomes. But one thing that we know and that we've kind of seen anecdotally is that the kids that are doing well are the ones that have found some way to stay connected with their friends, that are staying in touch, somehow maintaining those relationships, having fun, doing things together, whether it's through Xbox Live or all the different ways, all the different social media, and that kids that have disconnected, have stepped away from their social relationships, are having more depression, are doing less well. So it is important for families to try and find ways to help their kids stay connected with peers and their friends in some safe, socially distanced way to support and protect their mental health. Okay, so those were kind of the risk factors, so things that make it more likely for suicide to happen. And now I want to run through the warning signs. So these are the different signs to watch for in your child, to watch for in your friends, or maybe in yourself. If you start noticing some of these changes or patterns that are happening, it might be time to have a conversation with your child or your friend. So warning signs, someone might be thinking about hurting themselves. The first is that talking about death or dying. So any mention of dying, disappearing, shooting oneself, any type of self-harm is a warning sign. Disconnecting from friends. So not seeing people, not talking to people, or responding to texts, not engaging in social media if they used to. It's that change in their usual pattern of behavior. Also a change in personality. So if someone maybe used to be kind of happy, outgoing, bubbly, now seems sad, withdrawn, maybe they're irritable, they seem more anxious or worried, or maybe they're apathetic, they just don't care about anything anymore. We also watch for changes in behavior. So if they're not concentrating on school, that drop in grades, they're changing their work or their routine, they lose their interest in friends, or not participating in hobbies or activities, they're not doing those things that they usually enjoy, that loss of enjoyment. Change in sleeping patterns, so insomnia, so hard to fall asleep, hard to stay asleep, waking up too early, or maybe even sleeping too much during the day. And same with change in eating habits, eating more or less than's normal for them. Changes in self-esteem, so saying that they feel worthless, feelings of shame, feelings of guilt, self-hatred. Maybe they say things like, everyone would be better off without me. And then hopelessness. And we talked about hopelessness before, and this is a really big indicator. So believing that things will never get better or that nothing will ever change. So we talked about kind of all these risk factors and warning signs, but it's also important to talk about kind of the good things. What are the strengths? What are some protective factors that reduce the likelihood? And then how do we build on these to protect our kids or our friends? So some of the big ones are the availability and awareness of crisis supports to delay action. So if I'm worried about my child, what do I do? How do I help them be safe in this moment? Also support from medical and mental health care professionals, and access to effective culturally competent care. And I think this one is really important because when we talked about COVID, we talked about racial and ethnic minorities are disproportionately affected. We talked about how Lgbt youth are also disproportionately affected with mental health. And so making sure you have that culturally competent care is so important. And if at any point a parent is worried about their child, they're seeing any of these signs, anything is happening, we think it's better to go ahead, connect with the counselor, develop that therapeutic relationship. So if a crisis does happen, you already have that trusted relationship. You already know who to go to, who can help support you through it. Sometimes parents say, well, I want to wait and see. I think it's just because, this happened, let's wait and see. But if someone's depressed, wait and see is an effective solution. They need real treatment. Additional protective factor, so coping, having good problem-solving skills, good conflict resolution skills. The big one we talked about, restricting access to highly lethal means of suicide. So if you have weapons, firearms in the house, please make sure that they are locked up, that your children don't have access to them. And I feel like everyone has a story where the parent swears that the child didn't know how to access the safe, and then somehow the child did access the safe, whether it was an unintentional injury or an intentional injury. This one is, I think, so important. And before we talked about social support, connection to family members in terms of LGBT youth, but this is a protective factor also across the board. Family acceptance for sexual orientation, gender identity, connection to safe schools, and connection to peer groups like gay-straight alliances, and positive connections with friends who share similar interests. Also, having involvement in different extracurricular activities, so having academic, artistic, athletic achievements, having positive role models, mentors. These are all things that will build people's mental health and reduce the likelihood that they will experience suicidal ideation. Those are kind of the risk signs and risk factors and warning signs. So now we're going to talk a little bit about steps towards prevention. So we talked about looking for that change in mood or behavior. The other important thing is modeling healthy habits for mental health. So you have to take care of yourself so that your child know what to do. If your child sees you neglecting your health, you're not sleeping, you're not eating well, they know that you're anxious or depressed, but you're not seeking treatment, that really sets the stage for them to not do it also. But if they see you doing it, it normalizes it and it makes it part of your health care. And we said, don't wait for a crisis. Check in regularly with your child. This helps to build that relationship, build the trust, and gives them opportunities to tell you how they're feeling and then ask directly about suicide. And we're going to go through these in more detail. So I'm going to hand this on over to Dr. Claire. So thank you very much.
Great. Thank you so much, Rachel. So we will launch in just a moment to steps for action, taking action when you're concerned about someone, how to figure out if you should be concerned about someone in real time. But first I want to talk a little bit about the things that we tell ourselves that actually can keep us from taking action. I think for any teenagers listening, I encourage you to really, really think about these because it's something that we find ourselves telling ourselves about our friends often. So saying things like they're just upset about some kind of a crisis. Once it passes, they'll be fine. Or they only said it because they were angry or emotional at the time. They were joking, they probably didn't really mean it, or they've threatened that before, but they've never gone through with it. I must have misinterpreted what they said. I don't know them well enough. If they meant it, they would have told someone who's closer to them. They posted on social media, so I'm sure other people will help. You get some pretty big diffusion of responsibility with that. I'm worried, but I don't know how to help. And then lastly, they said it to manipulate me or get back at me. While some of these things may have a kernel of truth to them, it doesn't mean that the individual isn't going through some significant distress and that they don't need help. So in that context, then we'll move on to this model that's called Learn to Act. It's super simple, great language, acknowledge, care, and treatment. So we'll go through each of these in turn. First and foremost, acknowledging. So if you're afraid that someone you know is considering suicide, do take it seriously. If you recognize warning signs, it's important to take them seriously. And in fact, the majority of people who die by suicide had given some indication to someone close to them that that was something they were considering. That's certainly not exclusively true, but that does tend to be true on the whole. And all of us is responsible for that considering all of our friends and loved ones. Do listen attentively when someone is sharing with you that your friend or your loved one may even be more willing to seek help if you've listened carefully to them and if they felt supported by you. And do believe them. I think Dr. Rachael and I hear the phrase attention seeking thrown out when it comes to suicidal statements sometimes. And we want to caution everyone to be really careful of that and to consider what that actually means. When someone is accused of being attention seeking, I think we need to think about what are they seeking attention for? There's probably a reason there, and they're using a way that they're using whatever way they know how to signal that they're in distress. So let's take it upon ourselves to take that seriously and to know that they're signaling that they're in distress, and now we're going to know how to talk to them about it. So second is expressing care. Voice your concern. Take the initiative to bring up your concerns, even if it feels uncomfortable. This is just as true for teens talking to your friends as it is for parents talking to your kids. And we'll talk about some specific language that you can use in just a couple of minutes. Let the person know that you care. Make yourself available and show interest and support. These topics are uncomfortable, but if you are able to just disengage with what you're doing and make yourself present and put your phone down and turn away from what you're doing if you have a concern, reach out if you have a concern, that can really go a long way. Remain calm. That can be a pretty tough one. It would certainly upset most people to hear someone expressing thoughts about suicide. But if you can assure that person that you are there for them and that you guys can find help together, that can help that person be more comfortable sharing and continue to express what they're feeling with you. And then this last one is really hard. Ask if the person has a specific plan. So Rachael and I as psychologists have a lot of training about this, but I don't think it's outside your scope as a parent or a friend or a caregiver to learn how to do this. So when someone says to you, I wish I weren't here, or says, yeah, sometimes I do think about dying, the next step would be to say to them, gosh, like that sounds really intense. Like, have you thought about what you would do? Have you thought about how you would do that? That language is hard to use. That is scary. Those are scary words to have to come out of your mouth. But we'll talk about this in a minute. Asking directly is really important. And then you can get a sense from that person of, no, I haven't thought about what I would do. I'm just really distressed by these thoughts, versus, well, I might, I would probably shoot myself, like if I got to that point. And then you can gather more information about, well, like, do you have a gun? Do your parents have a gun? Do we have a gun that we need to be careful of? So those are all questions that someone who's assessing that person's for suicide would ask. But those are questions that you can ask too, to help you know what are the next steps that need to happen for this person. We're going to talk a lot about listening and language and how to have these conversations, and it can be really hard to know what to say. So we want to just give you some tips and words. This quote is wonderful. Most people do not listen with the intent to understand. They listen with the intent to reply. And the problem is when we listen with the goal to reply, we think we need to have the right thing to say. And that does not exist, especially in these kinds of conversations. They're very unscripted. So if we change our goal to listening to understand, to connect, to empathize, we don't have to have the perfect response. We can reflect back to that person what we understand. I hear what you're saying. It sounds like, this thing that happened was super upsetting to you. It's got you thinking about hurting yourself, and that's really distressing to you. I'm super glad you told me what was going on. So that just takes pressure off having the right thing to say and puts the focus on listening. So we want to run through just a few communication tips in general for starting these conversations. One is setting the stage to help people feel safe. So these are communication tips speaking more directly, parents speaking to their children, but trying to put, kids and teenagers at ease and setting the stage for your conversation so that they don't feel like they're getting in trouble or that there's a problem when you're pulling them aside. I like the idea of having just regularly scheduled one-on-one time with your kids and teens and making a mental health check-in part of that time, especially during COVID. That's a really easy way to ask about it, saying like, hey, COVID's still happening. Your life is still turned upside down, and so is mine. Like, can we just do a mental health check-in? How are you? I mean, I mean, I'm a psychologist, so obviously I love that language, but I think it's nice language to use. Secondly, super basic, but listen to them. Like we just said, trying to understand their perspective before offering suggestions. And I would encourage parents to be mindful of our own anxiety, which can prompt us to try and fix things, try and fix the problem. That's I think really hard to avoid that knee-jerk, I need to fix the problem because my kid is in distress. So just check in with yourself, be mindful of your own anxiety during these conversations. Affirm them, support their need for help. I encourage parents to thank their kids and teenagers for sharing with them, letting them know that they appreciate that it took a lot of courage to say those things and to have those conversations and be open. And then lastly, don't be afraid to say, I know. I think that creates some of the most genuine moments that you can have with a person where you're in a conversation and you get to a point of, I don't know what we do about this, but I'm here and we're going to figure it out. This is a big one, so it gets its own slide. Talking and asking about suicide does not make it more likely to happen. So I think that's a pretty common misconception. These are scary things to talk about, but really rather than putting thoughts in your child's head, these conversations assure kids that you care about them and gives them a chance to talk about their problems. The more comfortable and confident you are in asking about these things, the more you create a safe space for people to share with you. And that goes, for teenagers talking to their friends as well. Hey, I've noticed blah, blah, blah is off with you lately. Are you good? Are you bad? What's going on? Interestingly, the most successful school-based suicide prevention programs, which are huge, actually train students to recognize depression in themselves and in others and to reach out for help. So really using this language it's destigmatizing and providing an opportunity to share rather than planting ideas. So how do we start the conversation? What are the words that we use? There's no perfect script for talking about suicide, but here are some things that you can branch off of. So first, mention what has been concerning. You've seemed really down lately. You haven't seemed like yourself lately. What's going on? And then state your support. Whenever you want to talk, I'm here to listen and support you. I won't judge, and I'll never stop supporting you. For younger kids, you can ask about physical symptoms like stomach aches or headaches, and then changes in feelings like getting upset or more angry lately. That's language that they tend to be able to understand. Sometimes I set the stage with younger kids by saying, sometimes when we're upset, our bodies can give us clues like stomach aches or headaches to let us know that something's going on, and then just ask, do you think that could be happening for you? So sometimes in younger kids, it looks a little bit different. And then, like I said a minute ago, ask directly. Say the words, are you thinking about hurting yourself or killing yourself? Say that out loud. Practice saying that before you say it to your kid or before you say it to a friend, because those are hard words to say. But those are the most effective words to say. Have you ever thought about hurting yourself or killing yourself? It sounds like you've been dealing with a lot lately. Does that ever get so tough that you think about hurting yourself or killing yourself? Oftentimes, if I have a kiddo who I'm working with who I know has had trouble with suicidal thoughts in the past or who I know is depressed, I will set the stage differently and I will ask, how often do you have suicidal thoughts run through your head even if you don't want to hurt yourself? So asking in a how often does this happen for you type of a way normalizes it in the context of depression and says it's okay that this happens, and I know that having those thoughts is not a direct path to I need to send you to the ER. So that's another way to have that conversation. Then the question becomes, how do I respond when my child makes a suicidal statement? I want to die. I wish I weren't here. I'd be better off dead. You'd be better off without me. If we map our learn to act model on, then we acknowledge, I'm so sorry you're feeling that way. I'm listening. We communicate care. I'm here with you. Help me understand how you're feeling, what you're feeling. And then we figure out how to get consultation or treatment. Let's sit together and figure out who can help us with this. So do get professional help immediately. That's the underlying message for treatment. Like Dr. Rachel said, depression and suicide are not things that tend to resolve themselves. Depression and suicidal thoughts are not things that tend to resolve themselves, and treatment is incredibly important, initiating those relationships. So treatment can look a lot of different ways depending on where the crisis is at. So let's talk about some scenarios. So what do I do if I see or my child or teenager sees a concerning post on social media? Each social media platform has a different mechanism for actually reporting, and that would prompt that the people who monitor those social media sites to check in with that person in different kinds of ways. So on Facebook, there's a report suicidal content option. On Instagram, this pains me to use this language, but this is their language. So you have to select report, and then it's inappropriate. You can talk about stigma, and then select the self-injury, area. On Twitter, you can submit a form, and on Snapchat, there's a report mean or inappropriate snaps, or you can file a general request for assistance. So this is something that you can do, I think, in a situation where you really don't know the person. You don't know how to get in contact. You don't know where they go to school. You don't know anything about them, but you see something and you have a red flag go up for you. Trust yourself on that. Pay attention to your red flags. When you read something and you're like, ooh, that does not sit right with me, trust yourself. Trust yourself. So then what do I do if my child or teen approaches me with a concern about a friend? So this is speaking directly to you as a parent. Assess the urgency of that situation. Ask a lot of questions. Let me see the text. What did they say to you? Did you ask them if they had a plan? Do you know if they have something that they could hurt themselves with? All of those kinds of questions. And then there's a lot of different options, and you may choose more than one of these. So there are crisis text numbers and crisis call numbers where that you could direct that kid to get on the phone with someone or to start texting with someone. You certainly have the option and are highly encouraged to contact that child's caregiver if you know how to do that, or contact the school if you don't have a direct line to the caregiver. And then I think there are situations where you might not be able to get in touch with the caregiver, or you don't know them, and the situation is a little bit too urgent for just directing that kid to call a crisis number because you don't know if they'll actually do that. And then your choice is to call 911. And what happens when you call 911 is that they send someone out to do a well check. Some police departments partner with mental health agencies, so it's actually a mental health worker who would go out to the home, but they would literally go and knock on the door of that person's house and check in and say, hey, we had a concern. In these situations, I've heard from teens on the back end of this that they get pretty upset about their friends getting upset with them if they tell on them or report these concerns to an adult. So if you as an adult are hearing your kids say, this is I'm concerned about my friend, offer to your teen, hey, you can blame this one on me if you need to. You can tell, if your friend says, I can't believe I told you not to tell anyone, you can say, hey, my mom took my phone. She saw what you were texting. I told her not to. Or you can say, my mom overheard our conversation, or my dad overheard our conversation. So offer to be the scapegoat, because this can be kind of a high stakes situation for kids and teens. Then finally, what do I do if my child or my teenager discloses suicidal thoughts or feelings, suicidal intent, or self-harm? So big three options are, depending on the severity or the urgency of the situation, your pediatrician can be a great resource for directing you to how to find counseling, how to find resources. They can do an assessment in the office. Another amazing resource in our specific community is St. Louis Children's Hospital has a helpline for parents that's called 4514, and you can call no matter how old your kid is. So that line is staffed by social workers, and they provide feedback about concerns and also link you up with resources and referrals. That is a Monday through Friday 9 to 4 type of operation. So crisis happens during regularly scheduled business hours, you can call them, but typically they don't. So that would be more of a resource for, I want to hook somebody up with counseling, I need to run this past someone, I'm going to call this number tomorrow morning, I'm not actively worried about my child right now. But if you are actively worried about your child and don't feel like you can keep them safe or don't feel like they can keep themselves safe, then you would take them to your local emergency department and they would do an assessment there. Or if the situation were escalated and the person was refusing to get in the car or was being aggressive or you were worried about that, then you would call 911 and they would come and help you transport your child or your teenager to the emergency department. These are all crisis numbers, so crisis hotlines and text lines. I would encourage you all right now, if you don't already have these numbers, to take a screenshot, take a picture, and program these numbers into your phones and ask your kids to program these numbers into their phones, because it's a little bit hard to sift through and find the right number when you need it. So behavioral health response, this first one, is actually a local resource. It's specific to the Eastern Missouri area, and it's nice that it's a local resource because they actually have a mobile outreach unit. So it's a crisis number that you can call, and if face-to-face consultation or assessment is needed, they can come to you rather than you going to the emergency room and waiting for 9 hours to be seen. So they have face-to-face crisis assessment as well as follow-ups and connections to local resources. So that's a great resource. Then the National Suicide Prevention Lifeline is the big one, staffed 24/7. Right below that, the red one, is the crisis text line. So text lines are super popular now because they're really accessible and non-threatening, and it's a really familiar mode of communication for kids and teenagers as well as adults. So they're also staffed 24/7. And then the last one in the bottom left corner is the Trevor Project, which is a specific resource that was designed for LGBTQ teenagers and young adults. Anyone can call these lines, but they're crisis and text lines, like Dr. Rachael was saying, that are providing specifically culturally competent care. And then lastly, what do I do if I want to do more? You as an individual modeling these conversations, modeling taking care of your mental health, I would argue is the most powerful thing that you can do, the most powerful impact that you can have. But there's also room for advocating for schools. So school-based suicide prevention programs have gotten much, much more effective over time as we're learning more about how to handle these situations. And so you can advocate for your school district to develop or implement suicide prevention programs and other resources. There are a lot of topics that are related to suicide that we have not talked about tonight, but one of them is the impact that different current events in media and even like streaming content can have on groups of youth as a whole, and schools are a great way to target that and to address those concerns. So pretty recently we had that Netflix documentary 13 Reasons Why came out. That was just a few years ago, and nationally we saw a horrifying increase in suicidal ideation and suicide attempts and suicide completions. And that was a huge topic of conversation in the schools following that. And if it wasn't, it should be. So those kinds of things happen in waves and happen all the time. So if you're interested, I would encourage you to advocate and find out what your school is doing and how your school district is having these conversations. But again, I think parents as models and teenagers as models for their friends of just normalizing and talking about these things and having these conversations is probably our most powerful tool. Thank you. So we are happy to, Dr. Rachel's going to come back over and we're going to mask up together. So we are happy to answer any questions or talk further about any of the topics that we covered. I'm happy to have feedback, whatever has come up for you all.
If you feel more comfortable, feel free to type questions in the chat and I'll read them to Dr. Claire and Dr. Rachael.
I was wondering if either of you ever go to schools to talk or give any sort of presentation to schools, whether it be to the kids or counselors? Yeah, what does that look like for you?
So I have never done that. That's not been part of kind of our mission at Ranken Jordan. But Chad's Coalition does go to schools and offers presentations. And I even knew someone that I think applied for that job to go around and do that education. So they're a fantastic resource. I think they do charge, but schools can probably work something out.
Yeah, I think in terms of going into schools, what they found in the research so far is that the programs that are the most effective are not a one-shot deal. They're programs where they're happening over the course of an entire school year, or they happen repeatedly year after year, where, yes, someone may come in and give a presentation, but then what happens is they're training kids and they're following up and they're doing in-services with teachers and they're a consistent presence in the school. So there are a lot of agencies that offer those kinds of things and some that have really good research support behind them. But yeah, they do tend to cost money. So that's a place where I think advocating for that at your school can be a great thing to do. Thanks.
I work in an ER as a child life specialist, and I was just wondering if you guys have any advice on what I could do to help. We usually have children wait there while they're waiting for their placement somewhere. Just any advice I could do to support them on that end.
Being there is a huge support. Like the fact that you exist is a huge support. Like whenever I've had to send a kid or a teenager to the ED, it hurts my heart not to be able to go with them and sit with them, because that is such a high stress time. And the feedback that I've gotten from kids is that sometimes something can just take their mind off of what's going on. So you can't hold on to that level of intensity for 9 hours, and you shouldn't, and that's really uncomfortable. And so I would say, like, it's okay to not be super intense, and to provide distraction and to offer to, if it's okay, you're in your setting, to offer to sit in the room so that mom or dad or caregiver can leave the room and take a break and just kind of not talk about suicide for a minute. Because usually by the time they get to the ED, the tension is kind of diffused and they're just exhausted and overwhelmed. So thanks for being there. Yeah. I'm really glad you're there.
Oh, absolutely. Thank you, guys.
I'm curious if you know what happens if you report on social media like you suggested, like what happens next?
I'm really glad you asked that question, because I don't for sure know the answer to that. I know that what happens when you call like the National Crisis Line is that if they get concerned about you, then they would call your local police department. So I would imagine that with social media, they would be able to track the location where that post was posted from, and may, depending on the valence of the post, may send someone to do a well check. But that's a really good question. To be genuine, I don't know. I should look into that.
Thank you. I never thought about that either until you mentioned it.
Yeah, it's a great question.
We have a couple of minutes. I kind of want to throw out like a random factoid that Rachel and I found that we didn't really know where to put it, but it was kind of interesting. So there's a kind of a buzzword out there, suicide contagion. People have probably heard that word before. And the sort of definition of suicide contagion is that when there's one suicide in a community, in a high school, or just like in a location, sometimes there are other suicides that follow in pretty rapid succession. That is definitely a phenomenon that happens. And there are things that increase the risk of suicide contagion, probably the most intense of which is how it gets covered in the media. So if the suicide is sensationalized, if there's a lot of attention paid to specific details of the suicide, there are things that media companies can get training on to better handle how they report suicide. But one of the things that I found interesting is that I think whenever there's a suicide, that idea of suicide contagion just gets brought up immediately and is very, very scary. And while it's definitely something that should be talked about, it really only accounts for between 1% and 5% of youth suicides are the result of a suicide in their community recently. So while that number is like between 1 and 200 kids and teenagers a year, which is not a small number, it accounts for a relatively small percentage of suicide completions that we see. So just kind of interesting.
Mm-hmm.
All right. Thank you all for
Yeah,
being here.
thank
We're
you.
super happy that you wanted to learn and gave us an opportunity to dig a little bit deeper into this topic for ourselves. So thanks.
Well, thank you for your expertise and thank you for sharing it with the community.
Thank you so much.
Thank you all.
Thank you guys.